feel keep, or can you have any self-esteem? Can you think about achievement? That is when you come to school. If you don't have none of this, can you? So you have some sort of physiological needs to be achieved, to be able to feel for other level. After that, you feel so comfortable, you can do so many things. You can be thinking out of the box, relax, be creative, so forth. Okay? So remember that. This is very important. I want you to remember the Maslow's hierarchy of needs. Okay? When I ask you to remember that, that means that's going to be a test question. So the first level and last level and between. Okay? So what is the first level? Physiological needs. So remember that. So you have to have this before you go to the next level and try to evolve and think better. So remember that. I want you to remember that. So self-actualization and whatever I talk about. Again, when you deal with patient dignity, you have to treat patient with respect. Communication is a big deal. Communicate clearly with patients. That's a big deal. Remember that. Again, communication. Remember that you are eyes and ears of the radiologist. Whatever you ask the patient, you're going to report it to the radiologist. So you have to, communicate very well, very clear to patients. Different kind of communication. We have verbal communications. That's the different kind of communication. This is the verbal one. So I don't want you to memorize it. Just know there is a verbal and there is a non-verbal. Okay, so non-verbal, body language. The tone that I can talk to you, the voice that I can change it, the pitch, and touch, body language. If I talk to you like this, if I talk to my patient like this, or if I talk to my patient like this, body language. And this is important. We sometimes touch patient is shivering or scared, it's like, it's gonna be okay. That's the touch. For emotional support, my hand was clean. For emotional support, for emphasis, for palpitation. For palpitation, you have to palpate patient as a technologist. We have to touch patient, but we have to ask permission. You cannot just touch patient and grab patient, and that's a kind of offense. So you have to ask patient, even the children. I'm going to touch your hands. When they said nothing, that means they are okay with it, okay? But you have to ask permission. Remember, touch is for what? Somebody read it. Call it.
Emotional support.
No. What is touch for?
Emotional support, emphasis, palpitation, and ask patient permission.
Okay, so remember that. When I is red, that means what? Yes. Okay, again. So this kind of touch is not permitted. Okay? So fingers, 2 fingers. Ask permission. Okay? Remember. So I go very quick because we have too much to cover. Again, patient, remember that not everybody knows your language, not everybody knows medical language, and so try to make your questions simple. So let's say this is anterior superior spine, so ACEs we call it. We don't say to patient, I'm going to call to your ACEs or iliac crest. We don't say, I'm going to touch your hip bone, okay? So we don't talk very fancy with patient, like in medical terms, and make it simple because not everybody has the college degrees, or some people, they don't even have any school or maybe very low level of education. So patient age, their ages, they're important. Elderlies, children's, the way you are talking and communicating with them different, okay? There is not a one size fits all, okay? So your tone, your body language, everything has to be different with each patient. So age groups, again, you can read that. Pediatrics, again, put yourself in that kid's level, gentle, nice, soften the room's light, the equipment, get it prepared, don't make too much noises, to move the tube and everything to children get scared. You can ask parents to participate, involve them. Elderly is the same things. Elderly needs more respect, compassion. Again, ask permission to touch. Offer warm blanket, and so forth. Terminal patient, important. You know, patient, you might meet them, the people that might be terminally diagnosis, and they come to your office or your room for examination. So again, you have to know how to deal with them. It's every person is different. You know, you are in the same house with your brother and sister and sibling and mother and father. You are all different, you know. So imagine bigger picture, and people come to you and you have to deal differently with each patient, okay? Don't say, oh, I'm gonna do my exam, I don't care. Don't cry, stop it. Or the elderly the same, you know. Everybody has to be treated with respect and according to their age, level of the disease, and so on, okay? Again, this is important. It's not in red, but I want you to remember the 5 stages of grieving. If patient, they are terminal, they lost somebody, they don't want to accept that. Of this, maybe they are a terminal patient or they lost somebody, they are in denial, they get angry by me, and they are bargaining, they get depressed again, and finally they accept, okay? So, this is not in red, but I want you to remember it, the 5 stages of grieving process. Please pay attention to this, okay? All right, that's awfully quiet. Conclusion, call it, read it. Communication.
Communication skills are essential to good medical imaging. A good communication process is a closed loop. Communication strategies need to accommodate the uniqueness of each patient. Patients enter the healthcare setting feeling vulnerable and outside their comfort zone. Medical professionals recognize these feelings and act with compassion and empathy for the patient's welfare. Aging and terminal patients present their own set of patient care challenges.
Okay, guys, that's all you have to know about this chapter. Again, if you need more question and concern about this, and you don't understand something that I cover but you don't understand it, please let me know. Again, you have to take patient history. I mean, we train you, each clinic, each hospital, they have their own protocol how to take questions. Some questions, they like nurses do the triage. They question everything and you just have to do the, as an X-ray, I'm talking about our community, our profession. I don't talk about nursing. But you know, when you come and nursing, sometimes in the hospital, they do all the triages, all questions, and you just do the X-ray. Say, okay, this is the order that just do the chest. But still, we have to communicate with patient in some level. You know, you cannot just put the patient there and just X-ray the patient. You have to ask, double check the ID, ask if the patient is a female, is a pregnant, and so forth. So there are some steps of communication for us. We have to ask patient, no matter what. No matter they have the full triage, you have to ask them again. Double ID tags and you know, date of birth and so forth. So patient history is very important. Depends where do you work, what do you do? Maybe you are working as an X-ray tech and a medical assistant, so you have to ask so many questions. you know, so maybe sometimes, no, you're in the office that you just do the x-ray. The question medical assistant do it. What, you have to know what is the concept of the patient history, why you do that. So you have to ask patient question, you have to collect data, you have to analyze it, implement it, and evaluate it. That's the concept of that x-ray technology with the patient. So you ask questions, so where that you have pain, what happened, so the doctor ordered the chest, but you have to ask further question. Are you coughing? How long you have that cough? What's going on? You know, a patient, if the patient answer your question and add more, let them talk. So you don't interrupt patient, okay? Maybe they cough and maybe she said, oh, I coughed like a month ago and it was blood in my cough. So let them talk. So don't say, oh, you have cough. Just, okay, x-ray, don't breathe, and do it. So let them talk and write it down so the doctor can, which part, I always ask a student if their hands, let's say patient comes and they have pain. So they wanna ask, what happened to you? Oh, I have pain in my right hand. So always ask them which hand, and you see, they said, patient said I have pain in my hand, but you see the requisition is for right hand and the patient holding the left one. They make mistakes a lot. So ask them, is it left hand or right hand? Oh, no, it's the left. Are you sure? Yeah, I have a pain. So okay, so you can stop the procedure because sometimes they make mistakes on triage. So you can go say to supervisor, oh no, this is not right, this is a left one. It happens all the time, all the time. So you have to ask those questions, analyze it, and know how to take a good x-ray and how to evaluate that, so send it to the radiologist. So again, questioning. So again, let patient talk. Sometimes you have to repeat patients when they answer your question to make sure that you understood it. So, because you have sometimes, you know, especially in here, there are lots of language barrier. So as you said, sir, you have a pain in your right hand, isn't it? Oh yeah, okay, yes, okay. So sometimes you ask question and they said yes, yes, because they don't understand English very well. So whatever you said, they said okay. So make sure they understand your language. If they need a translator, you provide a translator. So don't assume that whatever you said or whatever patient said is the right thing. So double check, clarify, summarize. Okay, I want you to remember that, subjective and objective. Can you read that? What is subjective, what is objective?
Subjective information is anything that the patient or significant other who accompanies the patient says in regards to care. Objective, anything you see, hear, feel, or read on the patient's chart or information given by another healthcare worker.
Okay, so what is objective?
Objective data, perceptible to senses, able to be measured, signs that can be seen, heard, felt, and so on.
Okay, so objective, you know, you can measure it, okay? So blood pressure, breathing, pulse, and what is subjective?
Subjective is patient feelings, pain level, attitude, opinion of observer, subject to interpretation.
Okay, remember, subjective is a subject to interpretation. Patients, oh, I have so much pain, I couldn't sleep last night. And if they're coughing and the attitude, whatever you do, there is an opinion of others, maybe mother, the daughter said, oh, did my mother, you know, she's always pain in her stomach. Somebody says something about it. So this is subjective, the feeling, subject to interpretation. This is measuring, okay? Okay, this is an example. Who wants to read the example? Arma.
A patient complains of a runny nose and cough, subjective. And
Yes,
it's the
patient
health-
said, I have runny nose and cough. So what is that? Subjective. What else?
As the healthcare worker observes the patient coughing,
So That's the objective, you see it. Okay, what else?
A patient complains of feeling stressed and anxious,
Okay,
while the nurse
Subjective.
is measuring the patient's elevated pulse rate.
so whatever measurable, objective, okay? Remember that, guys. Definitely test question, definitely. Okay, so after we have to analyze data. Can you read that?
Data analysis. This part of assessment integrates all segments of critical thinking. Once all the data has been collected, you must decide how you will achieve your goal to perform this exam with quality images, patient comfort, and safety and efficiency. This method requires all aspects of critical thinking.
Yes, so we analyze the data and we try to implement it. So we want a quality of image, but we have to pay attention to patient comfort and how to do it efficiently and in a safe manner, okay? Okay, so again, you implement it, take an X-ray, and you evaluate your X-ray. So remember, somebody read that for me. Element of the clinical history.
Elements of the clinical history. Chief complaint. MBS tends to focus on this. Permit the patient to add more than a single complement when it appears multiple complaints are valid.
Mhm.
Ignore all symptoms except the most predominant can cause you to miss other important clinical information.
So again, let patient talk. Don't ignore the symptoms. Sometimes there are symptoms that are important, but because you are in the hurry, you don't care, and you say, "Oh, okay, you have okay. Let me do your hand. Maybe it's fracture. Maybe it's not just pain. You don't know that. Let them talk. Let them say if there is chronic, they had it for a couple of months, and maybe it's arthritis. So the way you can treat the patient, maybe the patient just failed. That's why we have to ask patient history. What happened to you? Oh, I just failed. So that might be a fracture. Oh, I have that pain for many years. How long do you have that? Oh, many years. So it's a chronic. It's not a fracture, which is just doesn't. So you can treat the patient differently. If it's a fracture, you have to be very careful with the hands. If it's a chronic, you know it's chronic. She had it's arthritis for years and gets worse. You know what I mean? So that's why the questions, they are very important. This is definitely the test question. So who's gonna read that? Somebody with a loud voice. Blue hat.
Localization, extract area of PT, complain,
So localization. What is the area that you have pain? Okay? What else? Chronology.
Chronology, determination.
How long you
and
have that pain?
Of the symptoms,
Okay.
quality, the character of the symptoms, type,
You can see
amount
the
and size of, I can't see that.
severity of the symptom. Severity?
Lesion.
Or lesion.
I can't see that.
Okay, all right.
Severity, the intense quality.
So how
speed,
much you have
number of
paid?
lumps, and I can't.
Okay. Lesion.
Onset, what PT was doing when the
Patient.
condition began.
Aggravation.
Averaging situations that identify the issue, associated manifestations, other symptoms related to the chief complaint, GT complaint, and cardiac condition.
Okay, guys, again, this is the 7 element that require for the complete patient history, where the pain is, how frequent that you have that pain, this is what is the characteristics of the symptoms. If the patient has a chest pain, are you coughing? If there is a lesion, it's big, small, how severe the pain is, you can ask the patient. Like they ask you in the number of 1 to 10. Have you asked about that before?
Yeah,
How
the
severity
pain,
is
but the
your
pain
pain,
level
yes.
between 1 to 10.
So on one said, what happened that when your stomach start to hurt? Oh, I had spicy food in the restaurant, and after that, oh my God, I was in so much pain, you know. So you have some idea. The factor that make it worse, maybe when you lay down you have heartburn, you can ask for that, and so forth, and other things that associate with that pain. So you can let patient talk, and you have to know about these questions. Okay. So again, each institution is different. They said, oh, you have to just ask this question. The rest is for the nurse. Oh, you have to ask this question, but you have to know about this. Okay. I know you are not a nurse, but you have to know about that. Again, same things for patient history. So this is patient questioning is like you're interviewing someone, but you have to be concise. It's not a long interview. Don't be too chatty and talk about grandma, grandpa, but you have a limited time, but you have to be respectful. You have to have empathy. Don't rush patient, elderlies, especially children. Make sure to ask for the chief complaint, where is exactly the pain. You have to know that. Be clear. Look for the objective and subjective data, and make sure that you are the eyes and ears of the radiologist. So you have to know what are the questions and how to write the notes. Sometimes patient say something that, let's say patient has a wedding ring and they don't want to remove it, and you want to take the x-ray, you have to remove it, but they said no. So you have to write it down. The patient doesn't remove her wedding ring, no matter what. Or patient might have nipple rings and they don't want to remove it. So you have to ask questions. Do you have any object on your body? Because it's going to show on an x-ray. Yeah, I have my rings in here. So you have to remove. No, I don't want to remove it. Are you sure? Because it's going to show. No. So you have to write down the note to the radiologist. Patient nipple rings, because they're going to see what is that inside the body. You know what I mean? So you have to ask questions to know what's going on. That's the basic one for the taking an x-ray. So it has to be in detail, and you have to write it down. That's why you have to be eyes and ears of the radiologist, because there's something going on, the radiologist doesn't know. It's a foreign body, for object in the body, the patient doesn't remember, but you see, what is this? Oh, there is something in my body, it's just left there. Oh, okay, you have to write it down. There is something in here, so radiologist doesn't see, but there's a lesion, something going on in the second digit, so you have to write it down, whatever you see. Okay, so chapter 13. Chapter 13 is patient's movement. Why we do body mechanic? Why we have to do that? We have to have a right body mechanic. Why? Why? Somebody.
The purpose of a patient transfer is to safely move a patient from one place to another.
Yeah, we have to, take care of the patient's safety and take care of our own back pain, because if you don't follow the good body mechanic, because of your job, you have to move patient, not too much, but you have to do something. Some patient, they are coming from within hospital, they are just in a very bad position and they are very heavy. So you have to move them and with the help of other people, not by yourself, but you have to know how to use your body mechanic to do it correctly. Not to injure the patient, not to injure your back and your body, because you need your back for the rest of your career, okay? So what is the base of support? So we have to know about base of support, we have to know about center of gravity and mobility and stability muscles. So how we can use this to move the patient and, for on our own concept of the body mechanic, use the body mechanic properly. So what is red? That means you have to know that. So what is the base of support? Base of support is literally the sole of our feet. That's the base of support, isn't it? Isn't it? So somebody in the back who is very comfortable, read that. Yes, you, back, yeah. What is this?
Basic support. The basic support is the foundation on which body rests. Basic support is the area between the feet, including the back and surface area, in a standing position.
So this is the base of support. So if I separate my feet like that, isn't it better? I'm more stable? Or if I do like this? Am I stable?
No, you're
So yeah, you have to put your feet, both feet down. So that's the base of support. When it's red, what is that? When it's red. Okay, so again, I talk about, this is a good base of support. This is not a very good base of support. So, when stand feet apart, improve the stability, okay? As easy as it. So where is the center of gravity? Call it, what's the center of gravity?
Hypothetical area of the body where the mass of the body is concentrated, gravity works from this area. Typically at level of second sacral segment.
Yes, the sacral bone, and the second one, that's the, I mean, it's a hypothetical area, but that means we call it center of gravity. So gravity works from here, this area. So when you want to move an object, I don't have any object, so anyway. So let's see this one. So we have to get it close to the center of gravity, okay? So that's how you can walk like this. If you put it like this, it's not right, okay? So that's all this is not all about. So when you wanna, then like this is correct removing a, this is correct?
No,
Which one is correct?
no.
Okay? So that's how you can move things, move objects, but not like this. Get it close to the center of gravity. This is the whole thing, this is all about. Don't like that. We don't do that, okay? We don't pick up object like this, okay? So, bend the knee, and like this. Okay?
A little bit the part like.
Or yes. So remember that there are so many tips online that you can use. Holding object close to the center of gravity, permit easier and better transfer. Okay? That's what I show you. Remember that. This is the way that you can carry the object. Close to the center of gravity and like this, not like that, okay? Again, show you how to do the good body mechanic. Hold object close to the body, bend knees, don't twist your trunk, and push. Sometimes we can just push the object. If it's too heavy, don't try to be brave. Say, oh, I am a man, I'm a muscle.
Or
No,
Hercules.
You just push it. Push it with your, like that, Better than hurt your back, because I myself hurt my back, so because you move so many patients, and you're young, you don't realize it, and after a certain age, you're gonna have back issues. So watch your good body mechanics. You have different kinds of muscles, mobility muscles, stability muscles, mobility muscles like the biceps, hamstring muscles, they are mobility muscles, and we have stability muscles, that they are the abdominal muscles that we have. Okay? So we can use them. So who's gonna read that?
Muscles and transfers. For effective patient transfers and handling technologies should use mobile muscles for lifting and stability postures.
Okay.
Postural
Okay?
muscles
Posture.
for support.
Okay. Any question about that muscles? So again, guys, there are so many techniques that you can transfer patient. If the patient's lower limbs is not working at all, you need 2 people to transfer patient. Stronger person has to take the upper body parts, and weaker technologies, lower one. But a stronger one who will take care of the upper body has to be the one who is giving the order. Like on the by the time by I said 2 or 3, we lift it up. By the time I said 2 and 3, you put it down. So that's how it works. So you can't carry a patient that doesn't function, like the lower limbs is paralyzed. You can carry it by yourself. Okay? So you have to know all these rules. I mean, you're gonna learn it in the hospital. It's not a big deal that I'm saying it and you say, oh my God, I'm so confused. How can I do that? You're gonna learn all of this in the hospital by helping other technologies, by observing. That's why you go to the clinical side, okay? But you have to have some idea of how it looks like. Okay, so again, you have to tell patient what are you doing. Always inform patient. Just don't grab the patient from the surprise from the back, or just don't push the patient to the next level and say, oh, and the patient said, what are you doing? Okay, we're gonna take an x-ray. No, you have to let them know what you wanna do. Sometimes patient gonna help you, so you don't have to even do anything. Some patient, when they come to the hospital, I don't know, for some reason, especially elderly, they just sit in the, and you said, can you stand up? They say, yeah. Can you walk? Yeah, and you see they're walking, and they were like, okay, so I don't have to carry you. So you can hold their hands or their arms. So ask them to help you, as much as they can. Just don't do all the work, because they if they can walk, they do. But when they see the wheelchair, they don't want to do anything. Just to lay down there and say, okay, he's young, he can carry me. So again, so you have to know that the patient can walk. Again, check the patient chart to see if patient is able to walk. You have to have some information before to transfer the patient. Check the patient chart. So again, same thing. Again, what I said to you, let the patient do it as much as they can. Don't let them play lazy, because sometimes they can do anything that you want. So, but they are in the hospital, they think, oh, this is a nurse, he looks very strong, he can carry me. So let's have a free ride. So let them help themselves. Okay, I want you to remember that. Orthostatic hypotension. Somebody in the back. I want to read it. You read. Yes, please.
A sudden drop in blood pressure caused by a change in a patient's valve position, more pronounced in patients who have been bedridden for extended periods. Symptoms of orthostatic hypotension include dizziness, fainting, blurred vision, and slurred speech.
It happened to you? You lay down for a long time, you get up and you was like, ooh, you get dizzy? That's what it is. Orthostatic hypotension. So if your patient is an elderly, sometimes it happens. For a long time, you do the x-ray or GI study or something. Make sure when they stand up or they're gonna sit down, ask them to sit down first, make sure they're okay before you let them go, okay? Just don't grab them and say, okay, you're done, and they come and they collapse, okay? Patient in that room is under your hands, so you have to watch them, okay? If they fall or something happens, it's my responsibility. So you have to watch people that they, maybe they are feeling dizzy, they sit down, they say, oh my God, are you okay? I feel dizzy. When they feel dizzy, let them sit down a little bit more. So, okay, to minimize the severity of that, what we're gonna do?
To minimize the severity of orthostatic hypotension, have the patient stand slowly. Encourage the patient to talk during the transfer by asking simple questions. Do not send a symptomatic patient away and risk having the patient faint on the way to his.
Yeah, and even though they said, I'm okay, I just was dizzy, just hold their arms and make sure they are going to the safe place, wheelchair, whatever. After, when you send them back from your room, you're fine. Don't let them walk. And they say, no, I'm okay, and they might fail, okay? So, okay, so remember, whatever you wanna do with patient, with the wheelchair, hold the patient from the strongest side. Which side is stronger, which side doesn't have pain, which side she can put, or he can put his feet down, you know. Hold, and make sure for the wheelchair, always, what do you do? Lock the wheelchair. When you wanna, put the patients, from the wheelchair to the table, lock the wheelchair. Again, type of wheelchair transfer, there are so many types. You're gonna see them all in the hospital, and we're gonna, as an X-ray technologist, before you go even to the hospital, you're gonna have some training about wheelchair, stretcher, what's going, I mean, how many of you have HSC class? You have to have it, HSC class is part of the X-ray requirement. So get the HSC class before you come to the X-ray. I mean, when you are registered, you have to have the HSC class, it's mandatory. So in HSC class, you're gonna learn about everything. Transportation, vital signs, everything. So this is part of your HSC class even before you come to the X-ray. I highly recommend you get that HSC class because you needed it for the hospital. Okay, so again, wheelchair, how to assist patient. Again, a stronger person, who's the one who lift the patient, upper body part. They're all, you can read it by your leisure time, and remember, a ladder of transfer, this one required 3 people, okay? Not 2, 3 people. So remember that. One is always the main leader. One is ordering everybody, and the rest of the 2, they have to help each other. And I want somebody read the conclusion. Armin, read the conclusion.
Communication with patient and team members is critical to safe and efficient transfer.
So communicate, guys, communication. With the patient, with your team member, don't assume that they know what are you doing. Don't assume that patient knows what are you doing. Patient doesn't know anything. They might be afraid of your machine, your equipment, yourself, and maybe they don't like you, I don't know, you're a stranger to them. So try to build the confidence with a clear communication, have an empathy, and show that you are a professional. Yes?
Work as a transfer team with a clear leader during the transfer.
Follow the leader of the transfer. Who is the leader? Listen to them. Don't assume that you have to do your own thing. You have to work as a team. Okay?
Let the patient assist with transfers if possible.
Okay? Patient has to let them help you. Don't do all the job yourself. Okay?
Use a broad base of support and maintain your center of gravity over base steerability.
Okay?
Use transfer and positioning aids when possible.
Okay, so whatever aid you can take, get it, you know. Don't use your muscles a lot, okay? Ask patient help, any transferring form, if wheelchair, a stretcher, other people help, ask for help. Patient is a big help, trust me. You have to just ask them to help you, because they do. If you think that you need help, they do, they help you. Even the patient that they have broken hands or trauma, they can move. Okay, so don't hurt your muscles. 14. So immobilization technique, the quality of image gonna get affected by motion. If patient has motions, the image quality gonna get fuzzy and it won't be clear. So it's gonna have motion distortion. And positioning inaccuracy, patient has to position right to take a good quality of image. If the patient is not in good position, the quality of image gonna get affected. And motion distortion sometimes is voluntarily, sometimes it's involuntarily. The patient is just have some sort of disease that they are moving. Or so Sometimes they're children, they're just crying, can't do anything about it. So what we're gonna do, we have to find a method to immobilize patient, okay? Again, what is the first deal for immobilizing patient? What is that? Communication, good communication. If you try to let them know, sometimes even show it to patient. I always ask my students, show them. It's better than say, oh, can you turn into your left lateral position? And they were like, what? So just show it to them. So can you do that to me, sir? Can you do that to me? Can you do that to me? So they do it for you. You can see it, it's easier. And you don't have to touch patient a lot. Just show it to them. Can you lay on your right, sir, and do your hands for me like that? So they do. Can you bend your knee? Just show it to them. I want you to lay like this and put your hands and bend your knee. So they do it so quick. So if you don't talk to patient and try to move them as a log here and there and move the hands here and bend the knee here, it's gonna be so much work, I'm telling you. Just show it to them. I want to do this. I want you to do this. Put your hand like this for me. Can you put your hand like this for me? Do it for you. It's so easy. It's gonna save your life. So, shortest, you can do too short, but as much as you can do the exposure time as shortest. So, avoid patient's motion. So, if you do it quick, patient doesn't move much. So talk to patient, I want you don't move. Okay, sir, stay like this for me. Okay, when you breathe, just don't raise your shoulder, okay? So they don't do it. So talk to them. Don't assume that they know, they don't know. And be nice to them, okay? If you see that they have, and you have empathy, you're nice, so they work with you. So we have so many devices, so we can immobilize patients, sponges, sheets, sandbag, Velcro, head clamps, and so forth. So when you go to the clinical sites, and we have some of them in the lab, so you're gonna see how it works. So again, cervical collar, spine board, splints. So you see that's a sponge. So we're gonna do X-ray of the hand, we can put the sponge so patient doesn't move. You can use the sponge. Sandbag, you have to make sure sandbag is heavy. So they use it sometimes for children or patient, they have involuntary movement, but it's heavy, but you have to know where to put it because it's gonna affect the X-ray. So it's blocking the X-ray. So you have to, if you wanna do the X-ray, you cannot put this here, okay? Or if you want to do the hand, you cannot put the sandbag on top of the hand. We're going to teach you about that, but you have to know that sandbag is one of those immobilization techniques, which is heavy. Pay for children, she's not happy, but it is what it is. You have to talk to them. You have to ask authorization from their parents. Just don't come and grab the patient and just take them. And it's, no. Make sure what are you doing, parents has to be involved and authorize you, okay? Okay, stockinets, again, pediatric immobilization. The first thing is what? Again, effective communication, remember that. No force, don't say, oh, get quiet, don't cry, don't talk to patient like that. So gentle, be nice. I know some of them, they're crying like crazy, and sometimes we don't like children, and you're like, what is this? So, and the parents, they are kids, they are sick, something happened, they are afraid of you, they don't know you, so be nice, and follow the hospital's policy and procedures, okay? Don't just do whatever you want. Even if you want to do restrictions, you want to do immobilization technique, you have to know what are you doing, which device you have to use, okay? Okay, tracking, commercial. So we have like a pigostat, is this one for the chest X-ray. They put the babies there and kids, not the babies, and they do the chest X-ray because that's the only way that the baby can get immobilized and don't move. It's very uncomfortable, but that's the way it is. Unless the mother or parents can hold them to get radiation, they have to cover themselves with a shield and go there. But we don't allow, and we said, they authorize it because it's for the benefit of the child to take a right X-ray. So this is another one. This is for the pediatric octostop restraint board. Cervical collar. Can you read that? What is cervical
The
collar?
most common spinal trauma traction device is cervical
So,
collar.
cervical collar is a big deal, guys. You see, hopefully not, but in the emergency room, they bring patient with the cervical collar with a car accident. So that means that patient is maybe susceptible, is subject to fracture of the cervical spine. So they keep that until it's clear. So that means if they ask you to take an X-ray of patient's skull or cervical, you cannot remove that, okay? You have to take an X-ray with whatever it is, okay? So cervical collar is there, you have to take an X-ray with that. Unless after you take an X-ray, send it to a radiologist and they said clear, they can open it. They authorize you to open it. You cannot touch that, okay? See this one, see they are doing cervical spine, lateral, they put the cassette there and they X-ray like this. So they don't touch it. For the geriatric patient, the most critical things is just if they fall, they break something. Trust me. More you're getting old, more especially ladies, they have develop osteoporosis. The bone start to get frail, and they just fall from this much. Boom, something is broken. So they are under your hands. Please take extra care of the elderly patient. Don't work quickly with them. Just be nice and be patient. Who wants to read the conclusion? Can you read the conclusion?
Motor distortion is a key factor in final image quality. Use a very short exposure times in order to lessen the chances of motion distortion. Communication is an essential skill in effective immobilization techniques. Pediatric immobilization requires creativity and adaptability. Deal with patients according to department policy. Use immobilization devices when appropriate.
Again, when you can have a good communication skills and patient can listen to you, you don't need to use those devices. Unless again, children, they're out of control, you have to, but if I have to let parents know. But if you work with the good communication skills, you can let you don't need too much emphasize of devices, unless the patient is in a very bad shape, so you have to do. Okay, we're gonna go to vital sign. Vital sign is very important, guys. So our body naturally, normal body function naturally try to maintain a stability, get itself adjusted, get itself stable, because all organ of our body, they look like a community, they are working together, okay? They are helping each other, and the brain is the center one, and they are all helping each other to maintain that stability, okay? Biological stability. Sometimes there are environment forces, you get hot, you sweat, that's your body response to the heat, okay? So that's, we call it what? Homeostasis. So who wants to, okay, let's go to the next one. So when you go to the doctor or just for annual checkup, how many of you do the vital signs? Yeah, everybody. The nurse comes, they check your temperature, pulses, this and that, heart rate, respiration, blood pressure, even your doctor do it, and that's the vital sign. They want to make sure that all this process inside the body function normally, according to the normal chart that we have for the normal patient with age appropriate and patient size, ages, and so forth. So vital sign is very important. The first steps that every people, doctors or nurses, do it for the physical assessment. So body temperature, who's gonna read that? Yes. Say it loudly.
Between heat producing body tissue and heat loss to the environment. It is controlled by small structure in basal region of the brain called the hypothalamus. Changes in the body physiology occur when the body temperature fluctuates between 2 and 3 degrees, whether as a degree Fahrenheit or degree Celsius.
So heat exchange from our body and environment. Hypothalamus is the responsible person, no, not person, body part in the center of the brain, control that, and fluctuated, depends time of the day. I mean, for the pregnant woman, the body temperature is very different. So it's not, again, written in stone. There is a certain range that your body temperature is okay to be in that certain range. After that, it's going to be according to the chart. Is a fever, or your is below is not a fever, but something going on in your body. So in here in the United States, we usually use Fahrenheit, but so many countries, according to mine, usually use Celsius. So we go with Fahrenheit. Okay? I don't want to give you a hard time. So what is I want us to remember that normal body temperature for adult. The rest, you can remember it. It's good to know, but what is the adult called? Between what?
97.6 to 106.
That's it. That's all I want you to remember. Okay? It's on red. The rest, you can read it like children, it's different. Infant is different, children is different until teenage time. So you see everybody's temperature is not the same. Depends to the age, mostly. 97.6 to 100. So what is fever? Can you read the fever? Sorry, I forgot your name.
Oh, Gabrielle.
Gabrielle.
A patient whose body temperature is elevated above normal limits is said to have a fever, also known as hypothermia.
So remember hyperthermia. What is hypothermia? It's a fever. Okay, so can you read that?
Fever indicates a disturbance in the heat regulating centers of the body, usually due to disease process. As the body temperature increases, the body demands for oxygen increases.
So yeah, something is going on in our body. Fever is a good reaction. That means our body is working, it's functioning. So the body give us a signal, something is going on, help. There is a demand for oxygen. An entity come in. So yeah, our body is very smart. So what is the hyperthermia? It's a fever. What red means? Question. So hypothermia. Who's gonna read the hypothermia? Gentleman in the back. Hypothermia. What is hypothermia?
Person's body temperature is below normal limits, they're said to have hypothermia.
Okay, so what is that? Below normal limit. So hyper, fever, hypo, below normal. Okay? So you did? What is hypothermia?
Hypothermia may be improved medically to reduce the patient's need for oxygen.
Sometimes patient needs for oxygen a lot. Maybe they are in coma or something. But so they induce hypothermia, bring the temperature low, so the patient doesn't ask for too much oxygen. Okay? What else?
A person can die with temperatures above 105.8 Fahrenheit to 111.2 Fahrenheit.
I will ask you for the test question, but it's good to know that above 111, oh, God forbid, patient, I'm gonna die if I get this number. And below this one, 93.2, the hypothermia. So measuring body temperature, so many different ways you can measure body temperature. From oral, tympanic, rectum, axillary, and so forth. I want you to remember the rectum. okay?
The temperature as well?
Yes. It's kind of a little bit higher, but it's more accurate, okay? And you have to know why. Why? Why? Okay, I'm gonna let you. So they are all those devices that you can take temperature. Whoever get HSC class, they're gonna show it to you. Or the tympanic, how to do it, and so forth. Electronic, for oral, for axillary. Which one is the safest one? Axillary. But you have to wait a little bit more for axillary because it's lower the temperature, but it's non-invasive. The safest one is axillary. Axillary means underarm, okay? Question, concern? I'm sure you know all of this. Okay, rectal. What is that called, the rectal?
The site is considered to provide the most reliable measurement of body temperature. It is also in close proximity to the pelvic region or core temperature of the body. This method should not be used if the patient is restless or has rectal bleeding or hemorrhoids. Use a thermometer with a blunt tip, and it's rarely done on adults, mostly performed on infants.
Okay, so mostly perform on infants because of the core body temperature is here, pelvic area is more accurate. But we don't use it usually for adults, especially because they are agitated and they have hemorrhoid, you know, in the anal part, and for infant it's mostly used. Okay, so remember that. And remember rectal temperature. Pulse. You feel your artery pumping under your skin. Some area they are superficial, so you can feel them. That's the pulsing. Have you taken your pulse before? Radial pulse, the most common. You usually do it. Don't use your thumb because your thumb has its own pulse. Don't use it like this. Always like that, okay? So radial, and there, press, and you count 1 minute, and count your pulse. 1, 2, 3. So that's the pulse. Recorded beats per minute, okay? So there are 9 locations measuring pulse: apical, radial, carotid, groin, temporal, popliteal, and I'm going to show you the picture so you can see how it works. The most common is the radial one, carotid here. Some doctor likes carotid course better. It is what it is, you know. But the radial one, when you go to the doctor's office, they usually do that, no? Yes? Somebody, wake up, wake up. I have so much to cover. Okay, so again, popliteal here. Posterior of the tibial, pedal. I mean, I don't ask question about that, just remember radial one. And remember this, average pulse rate per adult, 60 to 100 beats per minute. The whole minute, 1, 2. So if my pulse is 65, is normal? It is, okay? If somebody is running to your office and said, okay, so don't take that person's pulse because it's gonna be abnormal. So let them sit down a little bit, okay? And infant, remember the infant is sit up under the 20. It's babies. So how to assess the pulse? I want you to remember trachycardia and bradycardia. Somebody read trachy and brady. Tachycardia.
Tachycardia is an abnormally rapid heart rate over 100 beats per minute.
So somebody who's always like that, that's a disease. We call it tachycardia. Remember.
Bradycardia is abnormally slow heart rate below 60 beats per minute.
So how you remember that? Brady. I used to remember that somebody do the brain, like this,
Mm.
so it goes slow. Now I remember. Tachycardia, bradycardia. Remember that. Maybe below 60, 100 beat per minute. They are they are considered as a disease. Okay. More about pulse, respiration. What is the respiration? Exchange of oxygen and what? Carbon dioxide. So we count that too. So breath per minute, and remember that. One breath, two breath. The whole minute has to be between 12 to 20 breath per minute. So again, they said it has to be quiet and effortless. So you don't ask patient, I'm gonna count your respiration, because they started to breathe faster. So while you are doing maybe taking care of the pulse, look at the patient's chest going up and down and count it too. You pretend you're doing something else and just count the patient's breathing up and down, and just maybe 30-second time it too. You know, you can do it too. Just count the breathing from the chest level. Patient breathe, you can see the patient breathing, unless they are very shallow breather. So you have to put your hands there somewhere, and don't say anything, and just okay, I'm just taking their pulse, but you are counting their breathing. Because if you tell them, they're gonna breathe abnormally. Unconsciously, they started to breathe. They're just gonna adjust their breathing. Okay, seated or supine position. So blood pressure. The heart, they count that what? What is that blood pressure? Measuring what?
Measurement of the force exerted on the walls of arteries during cardiac contraction and relaxation.
So a cardiac contraction, cardiac relaxation. That's we're gonna measure. So how we measure this? Measure it with that's the recorded with the, we call it millimeter of mercury, and when it's contracted, what we call it? Systolic. Contraction, first, boom. When you hear it, have you heard the blood pressure?
Mm-hmm.
You have to go to the HSC lab to hear that. So that's the first number, systolic one. When the heart relax, what is that? Diastolic one. Systolic, diastolic, systolic, diastolic. So that's how we can measure it. Okay? So during the relaxation of the ventricle, that's the last number. So we heard the first boom, thumbing. That's the systolic one, and comes when it's evaporated. The last, that's the systolic. Okay? Yes?
What is the supine position?
Laying down. Okay, remember that. Normal, adult, systolic and diastolic. Has to be between 110 to 120 millimeter of mercury. Diastolic 60 to 80 millimeter of mercury. The rest, you can browse, but I want you to remember that, okay? It's very important. Okay, so how many of you have a loved ones with high blood pressure? I have a couple of. What they call it? Hypertensive. So which means more than 140 millimeter of mercury. Okay, how many of you have people there with low blood pressure? So what is that? What they call it? Hypotensive. With what?
90.
Less than 90 sometimes. Systolic one, systolic. Okay, remember that. Okay, so how we can take the blood pressure? Now I know we have digital, you just put your hands there and everything goes well. But there is a sphygmomanometer. So sphygmomanometer, remember that. This is a test question. The blood pressure cuff's name is what? Sphygmomanometer. Say it again. Sphygmomanometer. So remember, you need a stethoscope and sphygmomanometer. I mean, they call it blood pressure cuff for God's sake, but just remember that that's a test question, definitely. So sphygmomanometer, stethoscope. So when you go to HSC class, you have to know all those things about the stuff. I mean, I know a student kept asking me, Miss Moen, we have digital one, they just put their hands there and everything goes. I said, I know, but sometimes you end up in a doctor's office or somewhere, and or maybe the digital one is not working. I said, call it, can you get the blood pressure of the patient and you don't know anything about anything and feel so embarrassed, and you are in healthcare and you don't know where is the blood pressure cuff, how you can use it, you don't know how to put the stethoscope into your ears, so you have to know it, at least for the sake of knowing. So what was the name of it again? So go try it again. Go home and try it. Measuring blood pressure. Patient can be seated, can be laying down, sleeves up. Again, I don't ask question about that. This is part of your HSC class. We have patient got oxygen sometimes, so we have to pay attention to the oxygen tank when you want to take an X-ray, when you want to transport patient from the stretcher to the X-ray table. So you have to know all those oxygens wiring on patient, and you cannot remove any wire, any oxygen level. Don't change anything unless you ask permission. Okay. That's the bottom line of the oxygen administration. Oh, this is important. Pulse oximetry. What is pulse oximetry? Oxygen level. That's oxygen level. Yes, count your oxygen level, hemoglobin oxygen level in the blood, and between 95 to 100. When you go to the hospital, they put it there in your finger. Have you had that before?
Yeah.
Everybody has. So between 95 to 100 is okay. During COVID, they even sell it, said that you monitor yourself, because sometimes there was no room in the hospital. They said if your oxygen level is, they did it for me when I got COVID, because there was no room in the hospital. So they said, okay, they put this in my hands and they said, okay, go to your house, and if this open, below 85, come. So I was just monitoring myself all the time. So they gave me so much antibiotic. I was very sick. I had pneumonia, but there was no room. So anyway. So remember that. Again, oxygen delivery system, they're all, you can read it by yourself. I don't ask any question about those. Just again, remember, your supervisor has to allow you to change anything regarding patients' wiring, oxygen, respiratory care items, and equipment, okay? Don't just elevate the level of the patient's oxygen or lower, or just remove the oxygen from patient's nose and say, I just want to take a picture. I'm gonna do it, put it back. So you have to ask permission, okay? There are all sorts of tubes that you have to know for respiratory complication, chest tube for intercalary space drainage. They are all central venous line tubes for feeding patients, blood analysis, blood transfusions. There are all kind of lining when you can take care of see the patient's X-ray, that you can see all those lining. So again, they are not read. I don't ask you about that, but you can read it in your own. Infection. Okay, I have half an hour to go over 2 chapters very quick. So pathogenic microorganisms go to your body. They don't belong there, so they create some sort of disease or infection. That's how it is. So they multiply in your body, they damage your body, and they secrete exotoxin. Exotoxin is like a chemicals that they secrete, is like a, make you sick. It's a chemical. Yeah, give you high fever, vomiting, seizure, depends what kind of microorganism you have in your body. So types of pathogens: bacteria, virus, fungi, parasite. Bacteria, they are very resistant. They have both DNA and RNA. I don't ask about this, but I just want you to know that. And some of them, they are so resistant. I mean, it happens to me. I got some sort of infection, and they keep changing my antibiotic, and it doesn't go anywhere. That was resistance. My disease, whatever was that, I don't know, some sort of infection. They couldn't find it, and they keep changing my antibiotic to kill that bacteria that was so resistant to me, to my body. So viruses, again, they either have DNA or RNA. They don't have both. So remember, virus, sometimes you have a cold, you're very sick, and you go to doctor, give me some antibiotic. They said, no, it's a viral. I can give you antibiotic. Virus doesn't need antibiotic. Doesn't give a reaction to antibiotic. Okay? We have fungus, yeast, and mold. Can you read it?
Two forms, yeast and mold, much larger than bacteria. Medically important fungi are called dimorphic and grow as either a yeast or a mold depending on temperature and environment. Common fungal infections, athlete's foot, ringworm, tinea.
Yeah, athlete's foot. Have you heard about that?
Yeah,
Yeah.
I think there's a condition like when you grows too much.
Yes, if sometimes your foot is so much, damp in your shoes, and you don't change your socks. That's what happens. You get the fungi. That's what it is. In Florida is a lot because it's very humid and hot temperature. Mold and fungi, they love Florida. They go under your wall, everywhere. Parasites, sometimes they call some, I don't want to talk about you, I'm talking about some people, go to somebody else's house and stay and they don't move, so they are neither plant nor animal, larger than bacteria. So we're gonna go for this. So how we get an infection? What happened? We need an agent. Agent comes to your body. You need an agent to get sick, isn't it? Environment has to be ready. You get sick, isn't it? What else? Portal of exit. Some portal that infection exists. Maybe you just sneeze. That was your portal of exit.
Wow.
Means of transmission, maybe from droplets, maybe put my hands, which was infected, and you can put your hands there, and after you rub your nose. How about that? And portal of entry. Any portal that you have. Okay? Depends. So chain of infection agents, environment, portal of exit, means of transmission, and portal of entry. We're gonna talk about it. So infection agents, what are the agents? We talk about bacteria, virus, fungus.
Bacteria.
Yes, mode of transportation. You have direct transportation and come and cough to your face, or indirect one. You get there, you put it there, and you get it. Okay? So we have different sort of mode of transmission. So what are the direct?
Hand holding.
No, I asked her. Please.
Hand holding, coughing, sexual contact, touching of some sort.
That's the direct.
Indirect, vector, which is a mosquito, flea, infects person to person.
Mhm.
Then fomite, vehicle, food,
Okay.
water, equipment, inanimate objects.
So which one is that? I touch it, somebody come ask her to touch it. Which one is that?
Direct.
Indirect.
So, what is the name of that indirect? Vector or fomite?
Fomite.
So remember that. Touch this, somebody else, this is infected, I touch it, my hand was contaminated, I touch it, and she comes and talk to me and put her hands there and say, ah, my nose is itching, and there you go. So, which one is that? So, what is this?
Direct.
Contaminated. What is the name of it?
Indirect.
What is the name of it?
Vector.
Vector. Okay, remember that? Remember my act? You like it? So, nice meeting you. What is that?
Direct.
Direct. What is that?
Direct.
Alright, so it's a direct. Okay, so some people got infected, come to the hospital. Before even come to the healthcare facility, they were sick. They had infection. So we call it community acquired infection, okay? But this one is important. This one is test question. Nosocomial infection. What is nosocomial infection? That means I come for a x-ray. I just fell. I went to the emergency room for hand x-ray, and it was so infected over there. They didn't clean it much. They didn't disinfect the table, whatever was that in that room. So I end up to have pneumonia. How about that? That's the nosocomial infection. Okay, somebody read that. Call it read.
Develops when a patient is staying at a healthcare facility and was not present when the patient was admitted to the facility. At least 5% of patients hospitalized each year in the United States develop nosocomial infections. Many are preventable.
Okay, so it's preventable. It's very uncomfortable for patient. So remember HIV and HPV, they are blood-borne pathogen that they are part of the nosocomial infection. There is a vaccine for the HPV, hepatitis B. So when you go to the hospital as a X-ray tech, you have to have that vaccine. Is it recommended? You have to do it, unless you have some reaction, the doctors say otherwise. But it's a mandatory, because they are there in the hospital, part of the nosocomial infection, and you have to be, protected. HIV, HPV, remember that. You can read it on your own. So, okay, how to control infection? Asepsis?
Environmental, easiest method of control, preventative, asepsis, freedom from infection, surgical sterilization, medical temperature, chemical disinfectants, antiseptic, topically applied, bacterial, static agents prevent bacteria to grow, bacterial rid.
That's okay, don't worry about it. Just remember it is.
Agent causes cell killing, and then physical barriers, gloves.
So remember, guys, thank you. Remember, guys, so if there are surgical sterilization, they have their sprays, chemical sterilization, you have to protect yourselves against infection as using masks, gloves in any area that they are, you have to protect yourself in infection. Control.
For that one, we have to know the physical barriers.
No.
What?
The one that I asked you to remember, that just remember that. Remember that mask, gloves, gowns, there are isolation methods that you can read it yourself. I don't ask those. This one, contact isolation. Can you read it?
Two types of contact spread of infection. Direct contact, when a susceptible person actually touches an infected body, or indirect contact, when a susceptible person touches or comes in contact with an object that has been contaminated.
Okay, remember that, guys. I just want to remember that. The rest you can read it yourself. The isolation room, how you can take care of the isolation. Okay, this is important. Hand washing, hand washing, hand washing. As easy as it is, people don't do it properly and they get sick. And they put other patients, other people sick. Even the COVID is gone, you have to wash your hands after you leave this class. How many things you touch, you come to this class? And you can't touch that doorknob, all of you. And you go home, and you eat, and you put something in your mouth. just one person got sick in here, has something in her hands or his hands, you are done, okay? So hand hygiene, hand washing must be performed before, after seeing each patient. Again, this is part of the process. Wash your hands, wash your hands. Nails, fingernails short. They are part of hospital policies. Some girls in our program, they just resist it because they have, what is it called,
Acrylic.
Yeah, and they are not recommended. They are gathering pathogens, you know, you don't know that. Even the short one, they are not part of your finger, I mean nails. So they are recommended, you know, we ask them to, even the lashes, long lashes, they are carrying, they might carry pathogenic substance, and the excessive jewelry is not recommended. So you have to know all of this. Some people, they think they have to be look very fancy to go to the hospital as a worker, but you know, even long hair, your hair has to be tucked in. They are all might carry something. Okay? Where are you? 18 maybe? Oh God.
I think it's up to 17, isn't it?
17?
Yeah, just 17.
We just did 17.
I did, I'm 18.
Yeah, but you
We
didn't
don't have
open 18 for us.
I
We don't
didn't
have-
put 18?
No, you just have up to 17 for us.
Oh, okay, so I'm gonna put 18 because 18 is gonna be part of process. I'm gonna put it.
Okay, but it's not, I don't think it's any part of our homework.
But it's there. I'm gonna ask question during the test. I'm gonna put it, give it. I won't ask too much question, but it has to be there. Okay, so guys, how to disinfect, how to use the aseptic technique to prevent the infection. So, anything that involves that you insert something into the body, doesn't matter where, you have to use that technique, that aseptic technique. Okay? So surgeries, any catheterizations. So you're gonna go as X-rated to a surgical area. You have to bring your CR, isn't it? You have to bring your mobile X-ray. They ask you to do that. So you have to know how to, I mean, they're gonna train you. Don't get scared. I don't ask you all these questions, but you're gonna have some idea what to expect when you go there. So you have to wear the suits, surgical suits, and get ready to work with other people. So you have to know the sterile techniques. You have to know what is the medical asepsis. Can you read it?
The removal of or destruction of infected material.
Okay, so you have to know how to remove those infected area, how to get prepare the, you know, the so the sterile field, how open the medication with that, or the sterile, how to do the sterile gloves. All of this they're gonna show you in your HSC class, if I'm not mistaken. So there are zones in the operation room area. Some zones that the people can go and just with any clothes, but some zones they are semi-restricted, and some zones they are very restricted, that they are just sterile people. They can be around. The nurse, doctors, you cannot go get close to that area. So you have to know all of this. So they call it being scrubbed. That means nobody has to touch them, nobody has to be close to them. There is a nurse yelling at you, literally, don't get close to this area. And you say, okay. So when you go first time with your machine and everything, with your CR, I mean, you go with another technologist. They don't send you by yourself, but you're gonna see how that area is restricted when they wanna do the surgery, okay? I don't ask this question too much, I just wanna make sure that they are important. Okay, so again, surgical team, you have surgeons, you have surgical assistant nurses, and you're gonna be part of the surgical team, but you are not as close as the nurses and the doctors and the assistants, but you are the part of the team, so you have to know how to handle the machine and everything, okay? So you have to have your own radiation protection, your own radiation badge, your own gloves, your own equipment. They don't give it to you. You have to get ready yourself. So you have to bring your C-arm. You see your C-arm is there. This is you. This is the team. Okay. So what they're gonna cover the C-arm. They're gonna wrap the C-arm. They're gonna make it sterile. See? They have to cover it because the C-arm get close to the patient, so they can wrap it with a sterile material. You don't touch it. They're gonna do it for you. Okay? I don't want to scare you, but you have to be in communication with the surgeon. I'm gonna send this to you guys because I want to go over. Just make sure when you open the sterile material, make sure the date is not expired. The sterile package. They ask you, okay, Khaled, go open the sterile package for me. So the date change. Look at the date. If there is any opening, anything that you see the box is open, that means it's not sterile anymore. Even a crack, anything. So report it to your supervisor. This is a crack in here. I mean, this expiration date was yesterday expired. Can I open it? No. So you have to pay attention to this. And even how did you open it? I put all of this information, like videos. You can go and watch it by yourself, how you open it. You're gonna see it in HSC class. This is part of your HSC instruction. But just make sure you open it in the corner, you don't get close, you don't put your hands in the middle of the field. So they're all videos, just copy paste them and check the videos to see how you can do it. I don't ask questions, this is part of your HSC class questions, but I just want you to have some idea and to get, familiar yourself with all those idea how to do it. Expiration date and yes, that's it. So I'm gonna go over the test.
That's all for number 18?
Yes, 18 I'm gonna send it to you.
But that's it for going
That's it.
over it? Okay.
Yes, sir.
When is the next test?
The 14th.
Next test is
March
gonna be
14.
March 14.
Okay.
Okay guys, I'm gonna go over the test very quick. Remember the human diversity you're talking about? Learn about human diversity. The characteristic of the human diversity. What are they? Ethnicities, age.
Oh wait,
so
this
forth.
is going over the March 14th test?
Yes, test
Oh,
question. Human diversity, characteristic of human diversity. Study that. Gender, race, age, isn't it? So study human diversity, cultural diversity, what is this, what is that? I want you to study that. Study that direct and indirect contamination. Remember that we are talking about? What is direct, what is fomite, what is vector? I just talked about it. What was the vector one?
Mosquitoes.
Fomite one. What was that? Which one was that? Remember that. That Maslow here, hierarchy of the needs. Remember Maslow? I just talked about it. Basic needs, human basic needs. Maslow, that hierarchy. Remember that? Study that. Remember, this is which one is the lowest one, which one is the highest one, what they call. Remember self-actualization? I talk about it. You can be creative when you have all of those needs fulfilled. You can be creative. So you're gonna go to the level of self-actualization, isn't it?
Yep.
Am I okay? Do like this to me. So I said, good. All right. So touching is for what? I just talk about it. When you touch a patient, so what?
Support. Emotional
Support. What else? Yes. So
Palpitation.
yeah, palpitation, support. Remember touching. I put a highlight, red. So touching. So remember verbal and non-verbal communication. I just talked about it. Which one was verbal, which one was nonverbal. All right. Objective and subjective data. Remember that objective and subjective data, I just talked about it? So, patient facial expression is a subjective or objective?
Objective.
Subjective.
When you said objective and subjective?
Subjective and objective, study that.
Okay.
5 stage of dying patient, terminally ill patient, 5 stage of grieving. So the elements, 7 elements of the patient clinical history. Remember that? Aggravate. I can't even talk anymore. So again, remember, I just talk about it. It's chapter 12. I give you the chapter 2. Also right now. So chronology of the clinical history. Remember duration, frequency, I talked about it. Chronology of the clinical history. How often you have that pain, you know. Chapter 12. Chronology of a clinical history. Okay, so drop in blood pressure. What was the name of it? Sudden drop in blood pressure.
Hypertension.
So how we can transfer patient? Which side is
Stronger, which one is the weak side?
So what is the base of support? Just talk about it. Study that base of support. What was that? So how the base of support can be increased, get better? Closing your feet, separating your feet, how it is? How can the base of support can be increased? Like this? Like this? Or just like
Have
this?
your feet like solid, like
Okay,
stand.
so remember that. The collar, cervical collar, can we remove it?
No.
So, yeah. What we need to measure blood pressure?
The
Instruments.
Stethoscope.
Septic manometer and what?
Stethoscope.
Stethoscope. Yeah, remember that, blood pressure. I want you to study blood pressure. Remember the communication for everything, guys. Communication. So remember the center of gravity, study that. Study systolic and diastolic. Which one for adult is normal? Oh, I didn't go, so Google this. I don't want to give you it's there, but I don't know how to say. A state of deficiency of oxygen in tissue. What they call it. Google. I don't know. It's there.
State of what? Deficiency?
Oxygen deficiency in tissue. Yeah, you are bad. I don't tell you anymore. Go study it yourself. Okay, so vital sign again, guys. Study vital sign. What are vital signs?
The heart rate, checking the blood
What
pressure.
is pulse oximeter? I put it red. Whatever is red, study that, guys. Systolic, diastolic, vital signs, blood pressure. Taking temperature, again, you have to know that, guys. Vital signs, temperature, which one, the numbers, study those. What is pathogenic? Pathogenic. Best method preventing infection when you are working as a technologist is what? Mask. The patient is wearing mask.
For preventing infection?
Aerosol infection. Aerosol.
Oh, aerosol.
Aerosol infection. Okay, so direct and indirect transmission again, guys, remember that. What is sterilization? Remember vector, fomite, nosocomial infection. I just talked about it. What was nosocomial infection? I'm okay, go to the hospital for my hand x-ray and I get pneumonia. That's the nosocomial infection. You go healthy, you get it from the hospital. Okay? If you read it, you're gonna remember. I know I lecture a lot. Hand washing. So I didn't talk about the method of the sterilization. Remember, they are, we studied that in the chapter 18, method of sterilization. Okay, again, so remember, opening a sterile field, a sterile package, don't never touch the inside of the thread, okay? If you touch it, it's done. It's out of sterile, okay? Remember that. That's all the Kanban will remember. So whatever you think is suspected, is contaminated, what you do, you report it. You don't use it, okay? What else? That's it. If you don't get an A, I'm gonna be very disappointed. Yes, ma'am.
How many questions are there?
40, maybe 41. I'm gonna go check, but maximum 40, 41. Or 40. Guys, again, next week we don't have class. You have any question, you don't understand any concept of this, please let me know. Okay? I want you email me, you talk to me. Okay? Don't say Miss Moy don't answer my email, she doesn't talk to me. Please come sign in.
I was actually,